Well, thank you, Rashmi, John, the organizers, for letting me come here and learn. I got to say, this room is full of most of my systemic JAMAS heroes, so it's pretty awesome to be here. Plus the families and pharma and the regulatory agencies. Is a pretty impressive feat that you've got bringing these people together. So anyway, so this is my disclosure. This was an investigator-initiated trial, but it is funded by SOBI. But I'm going to give you backdrop. So this was the patient that got me interested in this disease and has really switched a large focus in my lab to studying macrophage activation syndrome. This was a child that, when Ed Behrens was a fellow, he and I met in Philadelphia. And she was 14 years old at the time, and she had had a long-standing diagnosis of something I'd never heard of and hope to never see again, which is cytophagic histiocytic paniculitis. And she was diagnosed at a very young age, had daily fevers to 104, if you can imagine, and total body paniculitis or inflammation of her fat and loss of her fat, lipoatrophy. And she had gone through various treatments, including TNF inhibition at the NIH, et cetera. But by the time we met her, I think she'd been on acupuncture, I think, for about a year and a half. And she presented to us with belly pain and a big liver. But she was physically the size of a 7-year-old from her chronic inflammation mostly. Not really knowing what this was, but reading a little bit and seeing the word paniculitis, we treated her with cyclosporin and corticosteroids. And she got a little bit better, but she returned to the hospital this time incredibly sick. Again with belly pain, she seized, which brought her back as well. She was comatose, she had elevated protein in her cerebral spinal fluid, she was coagulopathic, all her cell lines were down, her ferritin was up, her pro-inflammatory cytokines were up in her blood, and she was in multi-organ system failure. She was on multiple pressors, she had ARDS, she was in renal failure, liver failure, pancreatitis, she was bleeding out, she was in really bad shape. Ultimately, I think the sickest child that I've personally ever seen who eventually came out of the ICU unscathed. Is really quite remarkable. And her bone marrow showed this classic finding of hemophagocytosis, where this cell is engulfing other cell types. This we got a hold of from her prior history, which is the inflammation of her fat, so all these white blood cells that don't belong there. And they called us a little bit late into her hospital course, and she'd already been started on high-dose steroids and cyclosporin, and even started down the etoposide protocol before we were called in to see her, but she was worsening despite all of this. And this was late 2004, kind of Alexi had mentioned the first uses of Anakinra for systemic JA, and we had started using it by then for systemic JA, and it also seemed that blocking IL-1 was helpful for those kids who had MAS as part of their systemic JA, and this child was going to die. She was as close to death as I've seen someone survive. And so we talked to the family and considered initiating IL-1 blockade. And still to this day, it was nothing short of a miracle. Within 2 days, she came out of her coma. Within 6 to 7 days, she was out of the intensive care. Within a couple of weeks, she was home. It was really quite remarkable. And this really it was a big switch for me, and I think it had a lot to do with Ed's career development as well. And HLH and MAS to me are really the same disease, called different things, and she met all these criteria in spades. You can have a genetic diagnosis. Most people don't come with that unless they've had an episode before, they have family members with that, or you can meet these clinical and laboratory criteria. I like this kind of model of MAS or HLH, and if we even just take that out of the equation, so here is a very generic strength of your immune response on the y-axis with time moving along the x. Let's say you get an infection, the flu, for example. Your immune system is going to mount a response, hopefully. You'll tend to clear the organism, and then your immune system is also programmed to shut itself down. Otherwise, we'd be one giant lymph node or spleen, kind of like an ALPS patient or an LPR mouse. But the thought in HLH or MAS is that you have a group of white blood cells, these CD8 T cells or natural killer cells, that lyse these infected cells or antigen-presenting cells. But in MAS or HLH, they're defective in that. And so they actually interact. They stay together 5 times longer. And in that process, they spew out these pro-inflammatory cytokines that we've been hearing about, IL-18, IL-6, TNF, IL-1, whatever, which leads to the clinical scenario that we see as MAS. And these genetic defects for the familial forms can be in perforin or in any of the proteins that traffic these granules that contain perforin to this cytolytic immunologic synapse between the killer cell here on the left and the cell they're trying to kill here on the right. And perforin forms a channel and delivers a signal for the cell to die. But if you're deficient in any of these proteins that have these funny names, RAD27, MUNC13.4, etc., then this doesn't go well and is thought to contribute to at least a substantial portion of HLH and MAS. I also really like this model that's been put forth by several people, including Fabrizio, of this threshold model. So, like I said, we're not all inbred strains of mice, and in addition to that, there are multiple factors that go into the clinical picture that we call HLH or MAS. So if you're homozygous deficient, meaning both your chromosomes are missing perforin, for example, or mutated in perforin, you are going to get HLH or MAS. There's nothing that's going to stop that from happening. It may happen at birth. It may happen in the first couple of weeks, first couple of months, or maybe up to a year. But you're going to get it. There's nothing you're going to get over that threshold. There are certain organisms, for whatever reason, particularly the herpes virus family members, but other things like the flu or leishmaniasis in other parts of the world, that are also much more likely to drive your immune system into this state of a cytokine storm. And you may have a partial defect, like a heterozygous, one copy defect, that also gets you to that point. Or with, I think, a lot of the kids that we're talking about here today with systemic juvenile arthritis or systemic lupus or Kawasaki disease or some of our autoimmune, autoinflammatory disorders, you may be in a state of chronic inflammation. Maybe you have a defect in perforin like the Dutch have shown, or MUNC13.4 like Alexi has shown, and then you get an infection, and then you get pushed over the edge. So there's a lot of things that will get you there. And one of the amazing things to me is you get this burst of pro-inflammatory cytokines from this dysfunctional killing, and it's like, how are we going to fix this? And yet, if you target one of these cytokines, and it may not even be the most central one, but if it's the correct one or a correct one, you can bring it back under control, which is pretty remarkable to me. So we had this case, and then Päivi Matunen had started collecting a lot of patients, a lot. This was 12 at the time, a couple from our institution, mostly children with systemic GIA, some kids with various forms of vasculitis who developed macrophage activation syndrome and were not responding well enough to high-dose solumetrol, a corticosteroid, intravenous immunoglobulin, cyclosporin A. Some were also getting etoposide. And yet all 12 of these kids responded to Anakinra back in those days were relatively low doses for us. So it just kind of gave us this thought that maybe blocking IL-1 is the way to go, at least for these autoimmune or autoinflammatory patients. So I've been in Alabama after I left Philadelphia now for 10 years. And we get consulted on these kids in the hospital. And this is not, some of these kids are systemic GA, I think 12 of them were, but most of them are not. And these are patients, and this is not randomized or anything, it's just retrospective. 44 kids with a variety of disorders, 3 I think with leukemia, multiple herpes virus family members like EBV, some lupus patients, you can see, but I'm showing you the ones who have died. So our mortality is about 27%, and these are kids who have seen Anakinra. Now, they've probably seen a ton of other drugs along the way, but just anyone at any point who had seen Anakinra. And this tends to be better than the etoposide experience, at least what's published, which the mortality is more like 45%. But we've learned a little bit from this cohort. One thing is, and this is true of Alexi's data and other people's data and some of our other data, that about 1/3 to 40% of people with secondary forms of HLH, kids who show up later in life, have at least a heterozygous defect in one of these known familial genes. And that's much more than you'd expect in the general population. And if you're unfortunate enough to have an STXBP2 mutation, at least our data would suggest that that's not good. Most of those kids died. We also learned, looking at a variety of potential factors, that if your platelet count, for example, falls below 100,000, that's not good either. For the families in the room and for the physicians, all the 12 kids with systemic GA who had MAS who got treated with Anakinra survived, so that was good. And it's some kind of the obvious outcome measures. So the longer you're in the hospital, the much more likely you're not going to make it. And if your ferritin doesn't drop, and we may have issues with what meds you're on, and this may not be of value, but at least for this cohort, if your ferritin doesn't drop much in the first 2 weeks, that's also a bad sign. So simplistically, the way I look at this, for IL-1 blockade at least, with Anakinra, is like IL-18 binding protein, your body is making its own IL-1 receptor antagonist, and it just becomes overwhelmed with the IL-1 that's present, and you're just, by giving more, you're balancing out that excess IL-1. And there's a lot of reasons that I'm particularly fond of this drug, for a lot of reasons. One is it's a recombinant human protein, not that you can give endless amounts of insulin, for example. That's not safe. But in this situation, once again, you're just balancing out excess IL-1. It's very fast acting, so you're going to know usually within a day or two if it's going to help. It has a short half-life, so even if it was dangerous, which it generally is not, it's gone before you know it, so you can try it. It binds both IL-1 alpha and beta, so I don't know if that's important, but the monoclonal antibodies don't do that. And it has a ginormous therapeutic window. This is something that a lot of the newer biologics, particularly those that target cytokines, have changed medicine. Like, you can't double or triple the dose of almost any med you can think of, whether it's aspirin or an antibiotic or an anti-seizure med. But these drugs, in clinical trials, they gave them 50 times their recommended dose. And the benefit goes up and the side effect doesn't. And if you're in a bad situation, like you can't get IV access, some of these drugs can be given subcutaneously, like Anakinra. This was also some interesting data. So in the late 80s, early 90s, the intensivists also realized that people in the intensive care unit who were dying of sepsis, maybe it was not just the bug, but maybe the immune response that was killing the patients. And so they tried TNF blockade and they tried IL-1 blockade. And there were some suggestive data, but when they did more definitive trials, this was over 1,000 adult patients with sepsis, Anakinra did nothing. It didn't kill more patients, it didn't save more patients. So there was about a 30% mortality either way. However, when Bita Shakuri contacted Stephen Opel, said, can I just go back through your data, this is retrospectively, and pull out the intensivist definitions of what hepatobiliary dysfunction is and DIC or coagulopathy, their definitions, what happens to those patients? Because those two features are pretty common in patients with macrophage activation syndrome. And there it almost doubles their survival. So in a subset of patients who already have sepsis, IL-1 blockade suggestively would help their survival. So this is where we're kind of coming to. And I'm not a clinical trialist, but I am learning, and I probably made a lot of mistakes already, as I've learned this morning, in designing the trial. And I got to give Ed props too, because Ed was involved in helping us design this trial, along with Wynn Chatham, who's my adult rheumatology counterpart. And just FYI, there are a lot more adults out on the planet than there are children, and so it's about 4 or 5 times more common in adults than in kids. It's just under-recognized, just like it is in kids. And so this is a randomized, double-blinded, placebo-controlled trial using Anakinra to treat multiple types of secondary HLH or MAS in kids and adults. And I'm not going to go through this in detail, but we're using the new Ravelli criteria for systemic JA for MAS. Or if you don't have systemic JA, we kind of came up with our own. But we do require that you at least had a significant hyperferritinemia over 2,000 nanograms per mil, and then 3 of these various features. And the exclusion criteria is, I think, important. We didn't want to include malignancy. In our own 44 patients, all patients who had cancer died who received Anakinra. And we didn't want to include people who were seriously infected with bacteria prior to screening. We also thought it might not be a great idea to include those patients in which we think EBV is driving their disease, because perhaps maybe rituximab may be a better treatment for them. And we didn't want to confound it with patients who either came from an outside facility or before we got to them were already treated for MAS. We also tried to exclude familial forms, which are going to essentially need a bone marrow transplant, so anyone under 1 year of age or had a family history of HLH. We also excluded patients who were extremely ill, because this is a randomized trial, and we are doing it against placebo, although they both get steroids. You can see the various things here, elevated creatinine, severe hypoalbuminemia, mechanical ventilation, or hypotension. Now, they could develop that and remain in the trial, but not at the beginning of the trial. And we randomized them 1-to-1 to receive Anakinra or placebo for 3 days. So it's a short trial. It's kind of a phase 2, 3 kind of trial. But they both get Solu-Medrol at pretty high dose. So they're not getting nothing. And we analyze then kind of the things that everyone's talking about, although we don't have the S100 proteins here, we don't have IL-18 binding protein. In addition to that, we're doing whole genome sequencing to look for mutations in some of the genes that we might expect, as well as potentially novel genes. And we have evaluation criteria at 0, 24, 48, 72 hours. And then we have failure criteria. And at any point, and the partial response criteria are defined with these 5 criteria below. If you meet 2 of those, that's a partial response. If you meet all 5, that's a good response. And the good response at 72 hours is our primary outcome. But at any point, it's up to the clinician taking care of the patient. They can break the code, do whatever. And so if it's ever dangerous, you know, if just steroids alone are not helping them, you can do just standard of care. And then we have suggested standard of care, but they're not mandatory and not really part of the trial. So, like I said, the primary outcome is achieving a good response at 72 hours, and we're hoping to show that Anakinra plus steroids will do that better than steroids alone, and then we have a variety of secondary outcomes. And to date, we have 4 patients enrolled. 2 are adults with lupus, 1 child with lupus, 1 adult with adult onset still. We also have another patient that we've sequenced who didn't meet entry criteria. And interesting, the sequencing has been interesting so far. So we've only done 4 patients, but each one of them had at least 1 heterozygous or single copy mutation in some of these known HLH genes that cause familial HLH. And you can see the Still disease patient, this will be interesting to Grant, had a list mutation, which was found in 3 of the patients that he identified who had died from the flu back in 2009. So it seems to be a relatively common mutation that leads to this outcome. One of the adult patients had an STXBP2 mutation. Fortunately, that patient is still alive. The lupus patient had that AP3B1, 2 mutations actually. And the second adult was really interesting, had 5 of these different genes altered. And they also had an intronic mutation in the same place that Grant and Alexi and I have found mutations that actually regulate the level. So by doing whole genome sequencing now, we're not only finding amino acid changes, but we're finding changes in regulation of these proteins as well, or the level of the protein expression. So these proteins, like I said, they're all LIST, AP3, RAB27, MUNC13.4, et cetera, involved in delivering perforin. So here are the actual mutations we've identified in these first 4 patients that we've looked at. One of them was by computer modeling predicted to be highly deleterious, and then that same patient also has this novel intronic, never described before, mutation that may affect expression levels as well. And so I'd like to thank Sobi for agreeing to help us get this underway, and then we've had funding to do the genetics. And then I'm happy to take your questions if we have time.
So I think this is a very important trial. I was looking at the exclusion criteria, and I don't know if you recall number 7. You exclude patients on ventilation, patients with low albumin, with high creatinine. Isn't this a bit of a risk of a selection bias, that the worst sick children will not be included in your study?
Well, this is not, at least for us, this was not going to be the definitive trial. This was going to be like the first trial that say, oh, it's not just Dr. Cron giving his anecdotal experience, which I do a lot of.
But we're very happy it's a study now.
So we wanted to have, and this is only potentially 40 patients, although I don't know if we're going to meet that number, to tell you the truth. But so we thought about that, and it would be nice to include everyone. We're not trying to, it was more for patient safety than trying to exclude those patients, because it is placebo controlled, and so that concerned us. So, I mean, there's no, like I said, we probably made mistakes in designing this trial because I'm not a clinical trialist. This is like the first time I've ever done this. But, yeah, so that it is what it is.
So I also had a question about the prevalence of MAS. We already heard that it's quite a prevalent complication. Do you think that it would be wise to do the genetic testing in all systemic JAA patients for this HLA genes?
I mean,
would there be that the doctors would be even be more warned for this complication in such a patient that already is heterogeneous mutation on?
So there's multiple comments on that. So one is just because you have a mutation doesn't mean it means anything. So we're trying to take all these mutations we identify, go back to lab and study them, and we're working on that. It's a slow, arduous process, and even if we show it in the lab, doesn't necessarily mean it means anything for that patient, although I personally think that it does. I think it contributes to some level to getting over that threshold. As many people know in here, I'm an extremist on a lot of things. I mean, we do testing at newborns for things that are like 1 in 100,000. You know, these mutations, if you add them all up, it's somewhere between 10 and 15% of the room here is harboring one of those. And the ones that are more common, obviously, are more mild, and so it's much less likely that it's going to ultimately affect you. But you know, at some point, we're probably going to whole genome everyone when they're born, when that technology gets cheap enough. I mean, we're not that far off. But certainly, I say, boy, if I knew I had a known bad SDXBP2 mutation, I would put a bracelet on that says, if I'm in the hospital with a fever, start giving me Anakinra, please. No, I'm not kidding. And so it may get to the point, but yeah, certainly kids with systemic JAA, I think it's valuable. And it's gotten down to about $1,000 now. Some of these companies, they'll do whole exome sequencing and report on maybe 20 or 30 genes that they think are relevant. And if you push them, they may even tell you about a gene you're interested in that they won't report, you know. But yeah, it's a great question.
Well, I just really think it's important to point out about the SDXBP2, because that's the one where you had your worst outcomes. But you know, it's been shown that there can be dominant negative mutations, and all you do is leave a single allele to have FHL. So I'm a little worried that maybe you're missing FHL type 5, and that's why those patients are all dying, and they should get HLA-4.
Maybe. They don't all die, but a lot of them do. And you're right. I mean, Ed's trying to say that even if you have one bad gene, there are things called dominant negative. And we published a partial dominant negative, and another group at Penn published a couple full dominant negatives in that same gene. And a dominant negative means is if you had one bad copy, you got full-blown disease. But they're presenting later in life, so it's not identical to a kid who's presenting with a homozygous perforin deficiency in the first year of life. So whether they all need to be bone marrow transplanted, I don't know. But it's a good point.
So what we do is that we make functional testing. So instead of going for the genome, you can see if you actually have the CD107, which you can see if you have the granulocytes, and that will give you a very good marker for if there's a true effect of the genetic disease. And we currently have a study where we check all systemic JA and lupus patients from start. If they have a functional test, we go on to do the genetic testing if they do, and we are monitoring them, what's happening. But there are people who've done this, and it's actually not proven to be of such a benefit. We have a lot of patients who have mutations, and nothing have happened to those. So it doesn't mean that you will be sick, even you are heterozygous. But all the patients who have been sick, who had a mutation, also have a disturbed functional. So I think you can look at if you have a good lab, you can also get a lot of information for the functional analysis.
Can you say how often you found abnormalities in those?
Second last question.